Well, good evening, everybody. Thank you for coming. Today we have Dr. Jeff Dobro, who will be sharing with us his experiences in care coordination as a primary care physician and a physician executive across many institutions. So, Jeff, feel free to tell us a bit about your journey in healthcare.
You got it. I'm going to do two things. I'm going to give a very, very brief bio, and then I'm going to present a bunch of questions for the group to think about as we are having what I hope is a conversation. I'm a terrible lecturer, but I love having good conversations. So first, I am a physician. I'm a rheumatologist, an internist by training. I trained at NYU. And at one very early point in my career, the chief of rheumatology at NYU, which is this very highly academic program, thought everybody ought to be the chief of rheumatology or the chief of medicine somewhere. And in my exit interview, which was about 6 months before fellowship was over, he said, well, are you going to the NIH? Because I had a fellowship to go there for translational medicine. I said, no, I'm not going to do that. So, oh, great. So where are you going to be the chief of rheumatology? I said, I'm not going to do that. He said, well, what are you going to do? I said, I think that there's a better design for primary care. We could really think about putting the patients first instead of the doctors or the pharmacy or the hospital or like any of those other groups. Like, let's put the patient first. Wouldn't that be a wild idea? He's like, are you fucking out of your mind? That's why you can record this, because that's literally what he said. And the implication was, oh my God, we wasted one of these academic positions on a knucklehead like you. But I will share a little bit later the ideas that I had and how it eventually turned into a career, starting as a practicing doctor, but then, Paul, as you described, really building innovative solutions just out in the world. So really quick bio. So I'm retired, thank God, this is great. But I recently left Transcarent. I was chief innovation officer there for about three and a half years. And we did a lot of things trying to fix the entire US healthcare system, which we will do by the time we're all done with that. Prior to that, I was a partner and chief innovation officer at Mercer Consulting. Don't know if you ever heard of them, but they're a big global firm. They actually come up with healthcare policy design, actuarial work for large employers across the world. So that was a job there for a little while. I was chief medical officer at One Medical Group, if you've heard of them. Chief medical officer at Red Brick Health, which is now Virgin Pulse. I don't know if you ever heard of them. I was a partner at Willis Towers Watson, another large global firm. Had my own consultancy company, ran ACO, National ACO Development and Management Company about 25 years too early. And I'll tell you why, because it totally did not work for the most part. Was a medical director at an HMO, ran my own practices for a while. I did practice management for a couple thousand medical practices across the country for a little bit, was involved in technology, building EMRs and care coordination IT systems, which is important for today. And that's it. That's kind of my career. I am not 170 years old, but I've spent short stints between 3 maybe to 7 years doing each of those things I just described, trying to solve a very specific set of problems, much of which we'll probably touch on in this conversation. So I have questions for all of you to think about. Nobody has to answer, or if you want to answer in chat, that is like fine by me. Paul, you'll like listen to the answers and just interrupt and chime in here. So the very first question I have comes from kind of a strategy and innovation mindset. And I want you to think about like, what is the problem you're trying to solve? And that is actually a framework for solutioning. And we're trying to think about care coordination, right? Well, like, why? Well, what are you trying to solve in doing care coordination? And you could imagine, I'm not going to even answer that. But what are the problems that you're trying to solve personally or as a primary care physician in taking responsibility for care coordination? Like, that's a real question. Should you be doing that as a doctor? Should some other entity do that? Like, why are you involved in care coordination at all? And that's not to say that I don't think you should be, because that's not at all my position, but it's something you should think about because it's part of the bigger question around, well, what does care coordination mean in the setting of primary care? What's the value proposition for care coordination? Like, what's the WIFM? Like, what's in it for me? I don't mean me personally, but what's in it for the patient? What's in it for you as a primary care doctor? What's in it for the larger health system? Maybe what's in it for the fiduciary, whoever is paying for this, an insurance company, an employer, like somebody is paying for all of this. What about quality? How do we think about that? Where are the quality gaps? All of those other things, like what are specifically, like write them down. What are the value propositions? Because when you think about what your particular in your practice, you as a doctor, how should you be thinking about the value that you can bring? It's like, well, now the next question is, who does that value inure to? If you're working your butt off, you're like trying to do all these care coordination things, you've got a whole staff and a bunch of people are doing work. Well, who got the value of doing that? Was it you? Was it practice, your doctor, the insurance company? And I was an executive at an insurance company for 4.5 years, not my favorite job. I can share that another time. But like, who really gets the value of your work? And it will help you think about in your own systems, like why you're involved in care coordination, what you can contribute, who else needs to be responsible for this, who's going to pull these pieces together. How might you do it? Is it like human beings on phones? Is it AI? Is it somebody else? Like, who is it? So, with that, like, what are your personal goals? I mean, what do we have? Maybe 20 people on the call here? Like, personally, what is your goal? Like, what are you trying to get out of either learning about care coordination or really doing something? And then when we get back to this, the next thing I'm going to do, if there aren't specific questions, is tell you a little bit about the crazy model that I came up with that almost got me kicked out of my rheumatology fellowship. But one other thing for you to think about is, what are you coordinating? Like, what is that? What is coordinating specialists? Maybe it's a post-hospital discharge. Maybe it's around medication coordination. Maybe it's, right, we could keep going down the list of like, what is it you're coordinating? None of us are super people, right? You just can't coordinate everything. So what is it you're thinking about coordinating? And then the why, what's in it for you, your patient, what's in it for everybody else? And what do you even mean by care coordination? These are not easy questions. And they're ones that have really plagued me and everything I've been trying to do for 35 years. You need to think a lot also about, I'm going to call it the ownership of the patient relationship, but where do you stack in the priorities for a patient? Because they're being pulled in lots of directions, right? They're getting insurance companies calling them. They're getting they're getting specialists, they're getting their employer, they're getting their friends. They're going on to Chat GPT. They go, oh, maybe, that's who's going to pull all this together for me because I have no idea what the F is going on with my health. So think about who all of these other constituents are so that you're not working in a silo. Go, oh, it's my practice. I own this relationship. Well, you may from your perspective, but you may not from your patient's perspective or their family's perspective. And unless you understand all these other entities that are pulling at your patient, it's going to be hard to figure out first what care coordination really means, who you're going to be coordinating with, and what the value is. And if you don't understand all of those, you'll have no idea how to actually be effective to achieve the goals that you've outlined. So that was my provocative introduction to this. I'll share with you the one other provocative introduction I did around all of this was when I was chief medical officer, One Medical Group. I started 1 week before the big national convention, and they asked me to make some opening remarks, which I said, sure, I'm the chief medical officer now. I should be able to say something smart to 500 doctors. So I gave a brief introduction, and then I started like this. I said, well, what if there's a day when nobody needs doctors anymore? And I expected like to get hands raised, start a conversation stone cold. I thought the tomatoes were going to fly in my direction. They're thinking, who is this jerk who's now in charge of this large medical group? And they're telling me I'm going to be out of work soon, like no one needs me anymore. which was not at all the point of my comment. It was like, well, let's start to think about how health systems may develop and what the role of the physician really is, and understand all these other forces that are bearing down on us as the physicians and our patients. And if we don't understand all of those, how are we going to take our medical group and really move forward and lead progress around primary care in the world? So my position there didn't last all that long. I was really interested in value-based care and how we could bring technology and AI into primary care. And we had a new CEO that was like, well, how do we just get paid more fee for service and have more fee for service visits? Like, ugh, that is not where that's why we could say anything we want. You can record this because I told them this face to face. But this is not the future of primary care that I envisioned. So I'll stop there. So you have some questions. Maybe some came up in the chat. Paul, or maybe Eric, you had a question?
Yes, I see Eric asked something. Eric, why don't you say it out loud? That way you can fill in the blanks too.
Okay. So, of all the care coordination, that's like a gazillion different things, right? So, of all the care coordination activities, how would you stratify them in terms of most impactful to patients? Like the top three?
So I will give my answer, and then everybody, as I'm talking, put your thoughts in the chat here. That's what I really mean by having a conversation. But I'll share my personal views, and I'll share actually what the market is telling us. And then maybe I'll give a third answer around what I think the future might look like, if that feels okay. So to me, from the patient, I think about the patient's experience, and we think about I'm going to call it the navigation function, is from the patient's perspective. Most of them are so lost in the system because they have all of these different touch points or no touch points. And they're being told one thing when it comes from maybe what they looked up on Google, another thing from you as the primary care doctor, maybe they have a specialist, they've got a disease management company from their employer or their insurance company that's telling to do some third or fourth or fifth thing. So that idea of contextualizing somebody's health for them in a way that makes sense and gives them a trusted, guided path. So trust really would be number two, to create trusted relationships so that people can make their way through a confusing healthcare system would be number two. And then number three, if it's possible, it's pretty hard to do, is to have an understanding of what that whole universe of healthcare resources is for an individual patient. And it may be everything that I just described, and helping that patient prioritize what's important for them or what's most impactful for them. That includes specialist reports and diagnostics and disease management things and the internet and community resources. And so to speak a little bit to the future, there are technologies that are being developed right now. Some are kind of AI-ish based that would allow us to do that for each of our individual patients. All right, so now I want to see what people said. Paul, best outcome, absolutely. Least confusing to figure out, that's a really good one. That's kind of that navigation, coordination function. Cheapest, for the patients, that's pretty interesting because it depends on the population that we have. And the one thing I'll share with you is most research shows that most patients are not particularly motivated by cost, which is why healthcare transparency has had very little impact on total cost of care, other than maybe choosing one at a time diagnostic services. Patients don't know, don't care. And here's an insight that's based on doing surveys and focus groups over many decades. Patients actually associate cheap and bad. Expensive equals good. We know that that's not true, but that's what lay people think. And then fast, there's a lot to say about fast. Nobody wants to be in the unknown for a long period, so they want, like, get me the right answer as fast as you can. Like, Don't tell me I have to wait for my X-ray report for 3 weeks, or I need to get to the specialist 6 months from now. Like, I want to know right now, like, what's wrong with me? If nothing, that's great. If there is something, well, like, what am I supposed to do about it now? So that was interesting. Least confusing to figure out. I like that one. Someone for personal guidance, advice, navigating our healthcare system. Quicker, what's TAT? For an
Turnaround
appointment?
time, sorry. Turnaround
Oh,
time. just
turnaround time.
Someone to help guide them for an
Yeah.
expected appointment.
So on that,
Advocate for them.
I love that. So I'll share something around, Stephanie, your points there, if those, I assume those are yours. So one of the very first navigation, coordination, care coordination programs I ever put in place was called The Nurse in the Family You Always Wish You Had. Now, there was a short version of that, but like regular old people want to have a trusted person, and they trust the nurses, frankly, more than doctors. And like if I had one in the family, like that's who I would call. If I got some bad diagnosis or I came back from the doctor's office, like I had no idea what that doctor said to me. I just heard a mumble jumble of words. Like, who's going to tell me what all that meant? And Stephanie, as you said, who's going to coordinate all of that? And who's going to find my records for me? And who's going to make some like summarized sense of that? So that actually is what patients are asking for. And it is what the groups that are paying for all this care want. And from the surveys that we've done over the many decades with doctors, that's what the doctors want as well. Just help coordinate this thing for me. Therefore, we get to care coordination. Somebody, oh, Paul, you put in quality of care. So this was a project we did at Transcarent. You know, I hate to say this, but half the doctors are below average. Oh, yeah, that's just math, right? No matter what the metric is, that's just math. And there's a very funny President Eisenhower story that goes with that. His first Secretary of Education came in and said, Dwight, I got to tell you something. You know, half the kids are below average. And so Eisenhower literally said this. He said, that is not possible. I want everybody to be above average. It's like, that right can't be. But it doesn't mean that quality can't be better and we can move the bar higher and higher and higher. So one of the things we did at Transcarent is with a data management company actually built out a quality and what we call cost effectiveness set of indices. They're two separate indices, and actually developed those with the specialty societies that have built many of the quality parameters across the country, and said, okay, if this is how you and your specialty define quality, it's not up to me. I'm just, another doctor. I'm not the expert in this. With the measurements that we have, are you okay if we go ahead and try to measure everybody, which we just did? And it turns out that no matter how you're looking at outcomes or appropriateness or other quality measures, there's a pretty wide gap between, let's call it, the top 25% and the bottom 25%. And where would you want to send your patients to, right? And there's no way to know. Like, you don't have that data. I mean, I personally have it because I built the system, but you don't have it. Your peers don't have it. The specialists don't have it. Hospitals have it because they were one of the ones that bought it. And frankly, they didn't want to see the data. It's like, how could you not want to see the data? Oh, because Dr. So-and-so does more surgeries than the other doctor who's at the top of your list. And how could we tell Dr. bottom of the list that he or she is not doing a good job? They won't bring their patients here anymore. So there's another thing that you need to remember here is the economics of healthcare often conflict with doing the best work that we might want to do. So let's go through some of the other things. Have a care plan with goals of healthcare. Absolutely. Clear next steps. A clean and updated overall medical narrative and record. These are all, that is the essence of care coordination. Healthcare economically functions as a luxury good. That was a funny comment. Turnaround time makes sense. Cheap meds. Interesting. Ease of healthcare navigation, medical information. I think we're hitting on a lot of the same themes. So I want to talk a little bit about what all of you think your role is in doing care coordination. It can be overwhelming and you personally can invest a ton of resources in achieving all these things that we just talked about. You never get paid for it, or you don't know how you're going to get paid for it. I'll share what I did early in our medical practices. What do you think you ought to be doing? Some things in the chat would be really good. And while you're putting your, I'll give 30 seconds for you to chat, and then I'll just share with you, protect patients from the system, right? The evil forces of the big, horrible healthcare system. Look for some other good ideas, like right, appointment availability, right? If people can't get access, what's the point of even having a doctor? Right? It's like somebody you can't talk to. And then you need to think about, well, okay, well, what does access mean? Does that mean telehealth? Does that mean in person? Does that mean having the ability to just like walk in? Does that mean you've got someone else, some other expert that maybe isn't a physician that can answer a whole bunch of questions for somebody? But it's interesting. So we talk about, let's talk about access as part of care court. Yeah, I love that, building trusted relationships. Trust is an incredibly important concept in healthcare. And if you ask the average person, like, oh, who do you trust in your healthcare system? And you would list like a whole bunch of things. It could be your doctor, your nurse, your employer, the pharmacist, my neighbor, my insurance company. Well, who do you think's at the top and the bottom of the list? You get to vote in the chat here. You get to vote for the top, and you're going to get to vote for the bottom. Oh, wait, just a second. Most trusted entity could be a person, it could be a company, it could be anything from a patient's perspective in healthcare. And it has to do with care coordination. I didn't forget the topic of the evening. Yeah, bottom of the list is the insurance company. And the only one that ranks higher than insurance companies around patient trust are lawyers. That's it. Insurance companies and lawyers are at the bottom of the list. No one else ranks even close. So, right, family members, nurses are at the top. Actually, number one are the pharmacists, if you can believe that, right? Because they have no skin in the game. They just want to do the right thing for you. You're going to just get your medicine anyway. They're not there to rip you off. At least usually they're not. They give you shots if you need them, right? This is what the average person is thinking. So pharmacists are number one, nurses are number two, doctors are number three. Insurance companies just barely scrape above lawyers. Employers were pretty high. And it's interesting because if we think about those goals we had up above that we just talked about, like what about nurses that work for insurance companies? They're barely above the insurance companies. Because it's a conflict, right? When anybody thinks about what their insurance company wants from them, it's like, never send in a claim. That's what they want. And they're going to lie about, we want you to be healthy, or we want you to be the best care, or give you the best tools. It's like a total lie, which it's not really. I know a lot of very good people that do work there, and they really try to do a good thing. I'll give you a very short digression. I worked as a medical director for an insurance company for 2 years and then did other things there. Day number one, I get started. I don't even know where my desk is. The CFO comes in and says, how you doing? It's great, right? There's a terrific job. I came in with all these ideas about how we could manage care, which was a ridiculous thought that I had. I thought that was actually true. And he goes, here's your job. You pick up the phone, you say no, and then you ask questions. I'm like, you're kidding, right? That can't really be my job. He goes, no, that's your real job. Your job is to say no. I'm like, I hate this. I'm not doing that. So we had some conflict there, me and the CFO. Did not turn out to be great for my career at an insurance company. Okay, so we were talking about I love the South Park thing, by the way. So we're talking about what is care coordination and like, what are you doing? I'm going to share an example. I would love to hear some examples from you. So when I did not go on to my NIH job or become the chief of anything anywhere, I decided there was a better patient-centered way to create a primary care practice. And it wasn't that I didn't still love rheumatology and the science, because I still did it personally. But the idea was to build a practice around the needs of the patients, meaning somebody ought to be there in the morning when the kids are sick or people are sick and they don't know whether they can go to work or not, or be there at night, because why is my time more important than my patient's time? Like, they have jobs, they got kids to take care of, they have things to do, so somebody should be around at night. People want to have appointments. We talked around turnaround time, right? We talked about that. It should not be 6 or 8 or 12 weeks from now, unless that's the plan, right? We all have a plan, like I'll see you, once a quarter or every 6 months or whatever it is. But if somebody really felt bad today, I didn't want them to go to an urgent care center or the ER, which seemed wasted, and then nobody knew the history of these people or had a trusted relationship. So we said, all right, you know what? Why don't we allow people to just walk in? Not an urgent care center, because it's just like for our patients, but we're going to put one doctor in the group just as walk-ins. How about that? Well, you would think, Paul, you asked me, or maybe Kenneth was asking me, didn't like people abuse this? Where you had people in the waiting room that just walked in all day, every day? No, actually, we didn't. We didn't at all. The other things that we did is every single patient got a telephone call, because that was the best technology we had when I did this, within 2 days of every visit, no matter how minor, whether they walked in for a pimple or they had heart failure or whatever it was. It's like, hey, how you doing? And actually, I ran kind of a data analysis around literally the question was, how you doing? That was it. Like, that was as detailed as we needed to get. And people would say, I'm fine, or I'm not, or whatever it was. And it turned out about 15% of the time, we found a serious issue that people had. They either couldn't get their meds, or they were decompensating, or something bad happened, or they had an infection, or something like, oh my goodness, I'm so glad we talked to you. And we didn't wait, and you didn't have to go to the ER, because we had evening hours, or you could come in the morning, or you could just walk in. So if you were one of those 15%, it's like, great, just come on in. We're happy to see you. That's pretty cool. So the fact that we talked to people, we did another really interesting thing, is we picked our own small network of specialists. And if the specialists didn't treat people the way that we wanted, or answered our questions fast enough, or basically stole the patients away and did not allow us to coordinate the care of our patients, we said, no more patients for you. None more. Answer my questions, answer them quickly, answer them the way I want them, and we'll send you patients. Okay, well, that actually made us not popular with some of the specialists, but wildly popular with the ones that we wanted. Same around the TAT. I now learned a new acronym, but turnaround time is, I want my patient seen within 2 days. You can't do that? That's okay. Somebody else will do it. Good, high quality doc. And we built a very narrow set of specialists, which ended up working very well when I turned the practice into a largely capitated primary care practice, a lot similar to how you're doing your direct primary care work. Because now people knew they could come in, they could get appointments, that we would call them, they'd see high quality specialists, they had access, right? All of the things that we're talking about. And we did the care coordination. When people were discharged from the hospital, we were there on Saturdays and Sundays. So come on in and get your 24-hour, 48-hour checkup. There's another statistic, Eric, since you asked. There was a really interesting study, and I can't remember when it was done, but it was maybe 10, 15 years ago, looking at post-MI patients and medication adherence at 10 days, 30 days, and 90 days. Anyone want to guess what the adherence rate to all the medicines that somebody was discharged on after an MI in 10 days? Just put some numbers in the chat, like 100%, no percent. We're getting close. Non-adherence rates were about 30% in 10 days. At 30 days, it was close to 90%. People were not taking the meds they were supposed to. Right? And part of it is, oh, they didn't write me a prescription, or I didn't know, or I lost it, or the dog ate it, or, we did surveys on these people. Some of the reasons people would not take their medicines were just like unbelievable to me, and led to when I ran my ACOs, where we were completely at risk. I think we had like 330,000 Medicare patients, really sick people in these ACOs. So some of the reasons were like I didn't have any money. You would think that that was a common one. It was about 10% of the patients. I didn't have the money. I don't like red pills. Like, you're kidding me. You didn't get your pills because you don't like red ones? Well, how about if I get you green ones? Oh, I love green ones. I hate red ones. Red ones always make me sick. So like, all right, how about I call your pharmacist and get you the same medicine that's now not red? Would you like that? Oh, I love that. I'll take those pills. Like, okay. I mean, you've been in the ER every 6 weeks for your same AFib that I didn't know you didn't like red pills. That would have been great. So instead of not taking them, now we know. Yep, I love that other one. Meds remind me I'm a sick person, and I don't feel sick. I had a heart attack. I feel great now. Well, I don't need those stupid beta blockers, and that makes me, I don't know, I don't want to do it. Or, I talked to my friend who says after a heart attack, you do not want to take those pills because then you can't have sex. That was a really big one, even though they were wrong almost all the time, but the friend told them. So anyway, the point I'm making is that like careful follow-up and coordination and thinking about like where in the whole process of care do you want to spend the limited time and resource that you have in coordinating care? Like, where can you in your practice provide the best value to your patients? And, as I've shared with you, I always put the patients first. Like, where can you provide the biggest value? I love Paul's question. We're going to get to that one in just a second. So like, what are you doing? Not to patients, because that's miscategorizing the relationship. Now that's evolved from when I was in medical school. Like, you do things to patients. Like, that does not make sense. This feels like it's more of a partnership here. Like, we talk about things, we come up with a plan. You're the patient, you've got some responsibility. I'm the doctor, I have some responsibility. We're going to do whatever the things were we agreed we're going to do. We'll get back together in whatever it was, 6 weeks, 8 weeks, 12 weeks. All right, this is great. I'll share with you that exact point is around this relationship and whose responsibility and who's accountable for what in a shared responsibility relationship led me to leave a crazily lucrative career as a consultant and say, I got to understand how people just behave and how they think about their own health. And we created this, that was how Red Brick Health got started. It's like we originally wanted to start around people's lifestyle habits. Like, people know they shouldn't smoke, but they do, right? They know that eating the wrong foods gives them a stomach ache and rashes, but why do they do it? So it was a really interesting process, and one that was actually quite academic in developing strategies and understanding how to build a balanced relationship around shared accountability so that we could resolve this and build a different kind of relationship and teach people how to have that kind of shared accountability relationship with their doctors or whoever their professionals were. That, people are not helpless. Doctors can't make anybody do anything, right? And if an individual patient doesn't want to take any responsibility for themselves, well, then there's nothing much that you can really do, right? It just can't be done. So balancing that and setting that expectation, like, here's what I'm going to do, here's what my staff is going to do, here's what these other resources are, but here's what you're going to do. It always astonished me, like, as a rheumatologist, I have patients like for 30 years straight. So we would sit at a visit, go, okay, here's the things I'm going to do, right? You're going to take these meds, you're going to call me, you're going to do this, you're going to change your diet. Here are 5 things, right? You're going to do those things. And we'll see each other in 90 days. I'm sure you're going to start feeling better. Here's why, blah, blah, blah. Get together 3 months later. It's like, okay, I'm so excited to see you again. How did it go with all of those things? Well, no, I didn't do any of those things. Like, yeah, what do you mean? Like, I used to have a lot of hair and then I took care of patients and it all went away. But like, why didn't you do any of those things? And over time, I really wanted to study that and then help people understand themselves, how they could take better care of themselves. Because ultimately it's their life, and the time they're going to have a relationship with you, frankly, is limited, no matter how good you are. It is. People move, all sorts of things change. So one of the things that I found most helpful was helping people organize their own health life and start to think about personal individual accountability. But from the care coordination perspective, Paul, you asked good questions. Let's just get back to that. So if you think about like, why are you putting yourself in the position of being responsible for coordinating your patient's care? Well, we think it's going to make them have a better experience. We think it'll provide a better outcome for them. Here's something for you to think about in either the fee-for-service or the direct primary care world. And I'll tell you why. I invested several staff and built my own IT systems in a fee-for-service world. I got more patients. How about that? People like coming to the medical practice. We blew away the other primary care doctors in a town that I had never even heard of, in a people I never knew. I had never practiced at the hospital. I came from this academic crazy world at NYU and just plunked down doing a lot of research. And we just did the right thing by people. All of the things that we've talked about, like help me get a visit, tell me what's going on with me, call me, like, or send me a text or do whatever HIPAA allows you to do these days, but stay in touch with me. Show me that you care. I want to trust you. And I'm going to come back to you. And guess what? I'm going to tell my friends. And guess what? They're going to tell their friends. And guess what? They'll send you $100 a month because they did. Like, that's crazy. Or you can be in some kind of a risk-bearing primary care, larger environment, and you're going to get your bonus money because your outcomes will be better. Your patient satisfaction will be better. And the patients will love your medical practice. So it doesn't always have to be, how am I going to get $10 more a month, or can I submit a bill for this thing? Think about patient acquisition based on patient satisfaction, and they will just, if you do the right thing by them, they will love you, right? Yeah, think of care coordination and follow. It's like that was the single best thing we ever did for acquiring patients was call them. I didn't need fancy technology. I didn't need AI. I didn't need anything more than, like, this was a nurse, called people. The whole question was, how you doing? And then we let them come back if they needed to. That was like it. I know that seems like pretty stupidly basic, but like that was it. We went from 0 patients in a place where none of the doctors knew we didn't know anyone at all there. We grew to over 30,000 active patients in 3 years just by doing these basic things. But a big piece of it was people felt like they could trust us to coordinate the care. We could get them good specialists. We'd get them access. We'd answer their questions. They could get to us in a timely way. Now, if I were going to do this again, I don't even want to tell you what decade it was I was doing this, because that's a very long time ago. There's technology that you can use, right? That was just not available. There are data systems that you can use that were never available at that time. There's all sorts of things that you can do looking through your EMRs and using them to extract who might have the highest priority of need. How can you focus your care coordination on the people that really need it? There are better ways to stay in touch with your patients. You can do things like group visits. You might even have one of your favorite specialists. In my world, one of the things that we did, I was the rheumatologist, so it was easy. We said, we got like, okay, everybody with rheumatoid arthritis, next Tuesday, we're all going to get on a group phone call, because there were no video chats at the time. And, doing a group phone meeting was like a crazy novel thing to do, but it was great because it was curated, number one, so you didn't have, wackadoodle advice being given to people. And people loved it, and they felt, and they understood, oh, I understand my condition. I understand what to do. Somebody actually cares about me, is going to help me wrap all this together. And we created resource guides for people. Like, if you have this condition, here's a bunch of resources beyond the primary care doctor, beyond the specialist. Who else are trusted resources out in the world, whether they be specialty societies or the American Cancer Society or the local, AA group. There are a lot of things that you can do to help people. Okay, I want to get back to your questions. We're talking about life health coach space, says Dave. That's an interesting question. I don't know that particularly belongs in the care coordination space, but it is something that, as you think about how to empower people to live their best lives, so I'm assuming that's kind of what you're commenting on here, there's a way as a doctor you can help people do that, at least around their health. Now, you're not psychiatrists. I know that having integrated, mental health, physical health is a key element of successful primary care, but you're not there to be somebody's therapist. And separating that from offering good advice and helping guide someone to better structuring their life, they're different things. And that's not tonight's topic, but it is something that you want to think about. Michael asked a great question about the problem, of creating too many care coordinators. That's a huge problem. You have professional care coordinator organizations. There are insurance companies that do that. Employers try to do that. There are lots of different care coordinators, and that's why you need to think about your particular role in this. So it's fair to say, to ask somebody, maybe even in an intake, what do your health benefits look like? And they'll say, oh yeah, I've got the blah, blah, blah health advocate company. They're telling me everything about how I should take care of my health. Or, I do have a nurse in the family, and he or she they're just doing the whole thing. They showed me how to wrap up my records and prepare me for my next physician visit. Stephanie, your point is creating a great network of specialists. What should your approach be in entering a new market? I'll tell you what I did. It was very time consuming, but I went around and met them all. I just said, can you guys or women, can you all hang around a little bit, after hours? And I want to come over and just meet everybody. I also was pretty maniacal about looking up people's credentials, which does not necessarily associate with quality of care. But then as we went along, I asked patients, I said, how did it go? They said, that doctor, they didn't even talk to me. I also then learned over time, and it didn't take a lot of time, who was responsive, because I also created very specific referral. Well, then it was a piece of paper form. I said, here's the question I want you to answer. Answer the question, or I need help in treating this patient. I'm not sure what to do with this drug or that. It was a very specific question. And it specifically said, I'll just paraphrase the nice words that I had, is do not take over the primary care of my patient. Or if it was something that was so esoteric that it was like, oh my God, this is way out of my league, please take over the primary care of this patient and just get back to me. Let's see, what traits do you see in HR benefits departments of the most innovative employer-sponsored health plans? Great internal leader, industry. Okay, so, wow, a couple of those things. Over half of Americans have commercial insurance that is paid for by their employer. Okay, so just take that in. It's really important, because when you pay for something, you actually have a large amount of control over how the thing gets delivered, right? As much as patients and doctors should have their own independent relationships, which I think they should. If you're paying for your kid's school, you want to know, how's that school being run? Are those knucklehead teachers? Is my kid actually learning anything? Did they ever show up? What's going on there? I want to know. Well, if you're the head of human resources and you've got $1 billion budget, it's man, I want to know how that money is being spent. I'm going to share a very short sideline story of how I got into benefits consulting, which I had no idea doctors ever got involved in benefit. I didn't even know what benefits consulting was. But I spent 4 years working at a hedge fund. This was in the early 2000s because I hated healthcare. I was trying to do all of these innovative things, and I had my own independent consulting company, and no one ever wanted to do anything because it would always threaten their revenue, frankly, just to hit the bottom line there. But what I did learn in doing that for 4 years, it was during the time when healthcare inflation was going completely nuts, is I had access to ask CEOs and CFOs of the biggest companies in the country, hey, what are you doing around those healthcare costs? And when I first started, I got a guy. What does the guy do? I don't know what the guy does, but he does it. We have benefits. They get them. It's benefits. Why are you asking me that question? It's well, because it costs you $1 billion. And if you can figure out how to get people to be healthier and have better care, your earnings per share would go up by 10 cents, and I've got a 500 multiple on your earnings per share. That's why I care today. I'm also a doctor, and I care about people. Year one, I got a guy. Year two, I know the guy. It's Bob. He does the benefits thing. I don't know what he does, but it's Bob. By year four, it was like, oh shit, I can't believe healthcare costs are going up like this. Like, somebody better do something. Like, well, who do you think's going to do something? It's you. So in America, right, this is a capitalistic country. Employers are, for the most part, they're called self-insured, meaning it's literally their money. Like, they're writing the check every month for some other company like Anthem or Aetna. Some other company's going to administer it, but they're literally writing the check every month. So they started to pay attention. I said, ooh, here's a way to get leverage in the healthcare system in America. There's 150 million people who get their health paid for this way. And if I'm an employer, I want two things. I hired these people to do some work, so I'd like them to actually show up and do work and not be sick and hang out in the doctor's office or the ER, or be so sick they're not productive and I still pay for them. So it'd be pretty cool if they actually were healthy and showed up to work. Yeah, and this is costing me a bundle. I can't afford all this at 20% inflation every year. This is like nuts. I'm going to go out of business. I'm going to be a car company that spends more money on healthcare than on steel. Like, that's crazy. I can't do this. So I said, oh, wow. Companies care about healthcare. They're paying for it. If it's not coordinated, it's not high quality, it's not efficient, they're pissed off now. So I got to find a way to, like, take the fact that I can do better for Americans, for their health, achieve all these aims and say, oh, it's their money, it's their people, so it's a set population. Eric, to your question, and because of something called a law called ERISA, these self-insured companies make all their own rules. They can do whatever they want to do. They don't have to do what Aetna says or Anthem or anybody. They can do anything they want as long as it's fair and, like, not breaking any big laws. So that's how I became a benefit consultant. I tracked down Willis Towers Watson, which in a million years as a doctor, I would never have heard of Willis Towers Watson. I didn't even know what it was until someone said, you should call these guys up because they need someone like you. So I said, all right, I'll call them up. And they thought I was completely insane when I joined. But there was a lot that could be done. So the question about the most innovative employers, it's not by size, it's actually by the leadership running human resources, and then by the CEO and CFO. So if they really care about this, there's a lot that they can do. There's an easy case to be made that there's about 30% waste in the system, right? We have a $4.5 trillion system. So there's about a third of that is waste. That's like $1 trillion, $1.5 trillion. Think of what we could do in the economy with $1 trillion. Like, oh shit, that's a lot of money. Think of all the, like, we could actually pay people a reasonable salary for their job. Like, how about that? Or we could pay for kids to get vaccines, and, like, there's a lot that you could do. Or companies could just turn it into profits and perform better in the stock market. But then their people would still be healthier, which is, it's the country we live in, so that's the way things work. I don't mind that. So it's the personality, it's the willingness to do something different. It's the support they get from the rest of their company. It's also the culture that they live in. Like, unions are different than executives, which are different than lawyers, which are different than people who work in a supermarket. So understanding where the actual human beings are coming from is really important. I know we're getting a little bit off track, but just to get back to care coordination, I'll share some other statistics with you. In a commercial population across the country, I'll just tell you the answer. I was going to ask a question, but the question that I was trying to answer is, well, it can't be everybody driving all the costs. That systems don't work that way. It's usually small percentages of any system drive whatever the metric is that you're looking at. So it turns out about 30% of all the costs in healthcare are driven by 1/2 of 1% of the people. 1/2 of 1%. Holy shit. That's not a lot of people that you have to help out. It turns out that about 3% of the people are responsible for half the cost. And you know what the other 97% of the people have? Episodic issues that you don't have to coordinate or deal with anyway. Wow. Think about that. So think about in your practices, who you really want to spend the resources that you have. Getting back to my first questions, like, why are you doing care coordination? Are you doing it to help sick people be healthier? make the experience better, lower cost, improve outcomes. Those are really important things. And none of you have enough resources, not enough time, not enough energy, not enough money for a primary care doctor to solve all of those problems. So you're going to have to prioritize what it is you're trying to achieve. For me, what I was trying to achieve, I had two goals. I wanted the sick people to be healthier and not fall through all these cracks that we've discussed tonight. And I wanted to grow my practice. So I wanted people to have a better experience and trust my medical groups. You know, in the beginning, I had one practice, then 3, and then 58 across the country. And we turned all of that into a large national ACO. Some of it worked, some of it didn't. Okay, questions. Let's see. The C-suites and head of HR have visibility on employee health status. They have very granular insight into employee health status. They don't know that Eric or Jeff or Stephanie or Paul, they don't know anything about you as individuals, unless you're a catastrophe, and then they have to know, and there are reasons why. But they know that X% of their population are diabetics. They know that Y% have their A1Cs not under control. They know that only 4 people in the entire company have heart failure. They know how many MIs they know all of that. And that's how they would have hired me to say, can you coordinate all this stuff for me? Like, why are these sick people so sick? Why are 30% of them not taking their pills? Like, can't you do something? Can't you make those PBMs work better, or the insurance company or the doctors, or just do direct contracting for me, which was part of my last job at Transcarent, is we bypassed all of this and said, let's do 2 things. Let's direct contract for surgical procedures, because there are a bunch of knucklehead surgeons out there that are not doing good quality work, just to be frank. And there are a bunch of knucklehead primary care doctors that don't give a shit about their patients. So we want all of them off the panels, all of them. They're all off. Or you're going to pay for it yourself if you want to go to them, or you're going to pay $5,000 more to go to knuckleheads. And that gets back to that quality parameter, you know, that reporting that I could do. And we're going to make it super free for people to go to the good docs. How about that? Do you like that idea? You know, head of human resources, and some of them are like, whoa, you could do that? I said, yeah, it's your company, your money, your people. It's ERISA. You make the rules. You could do whatever you want to do. Like, oh, I'll do that. Eric, I love your comment there. So yeah, you could do that. So yeah, so your question was, do they have visibility? They have extremely granular visibility where every single dollar is going. Goes back to my prior comment that the CEOs and CFOs originally said, I got a guy. What does the guy do? I don't know what the guy does. He does it. We got benefits. They're things. They get them. And that evolved very quickly when healthcare costs became so expensive, which is why there is a role for DPC and primary care capitation and, you know, innovation around primary care and the evolution of bringing AI and big data and different kinds of practices together to just do this better. We all know there's no reason why any primary care doctor would tell a patient with hypertension, you have to come to the office every month. Well, there are primary care doctors that do that. They were in my ACO. I had to kick them out. Well, I asked them, why'd you do that? They go, because I get paid. Every time they come, I got paid. I had the nurse check the blood pressure. I said, hi, you're feeling good. I waved my stethoscope around and people went home. I go, well, that doesn't sound like a necessary visit. I had other doctors who said, oh, I see those people once a year. Like, once a year? Like, don't you have to see them more than that? Like, how do you know their blood pressure? I gave them a blood pressure cuff. They went home. When the nurse called them up, they said, here's my blood pressure. And if they were fine, I left them alone. If they weren't fine, I brought them in. So, oh, okay, well, that's the other extreme. But that works for you. How many of you people, you know, are dying in hypertensive crisis? None. They're fine. So there is a role for the evolution of technology, for care coordination, around you focusing on the things that you can do that will help bring all of this together to make the experience better, lower cost, improve the outcomes, and make you the popular doctors that patients want to come to in your market. All right, I know we have a couple of minutes. I'll stay a few minutes over. Let me just look at this. Is there any formal C-suite of doing something special about healthcare costs that companies outside of general HR? I don't actually understand the question. You know, there's a lot of thought that C-suites give around, we'll call it benefit design, or who they work with, whether it's hiring a care coordination company. You can look them up. Accolade, Transcarent, Quantum. Those are companies that do just that, and they all claim significant return on investment, ROI, or VOI, value on investment. And these are companies you can just look up. Go look at their websites. You'll see what they do. They do try to coordinate with doctors. They are trying to build technologies to make it easy for physicians to better understand what this larger universe of resources are for a patient. So if you do have a diabetic and they've got 5 nurses that are going to talk to them every month, well, you don't necessarily have to do that. You just need to know that they exist and get some information back from them. That's an example. How would a small or medium-sized business identify which specialists or who are in that lowest quality value tier? They have to pay my company a fair amount of money to get access to that network data. That's how. There wasn't just me. There are others that are building that. I think I did it better than anybody else, but no one's right. No one's complaining so far. But as primary care doctors, especially if you're going to form any kind of an organization, you could contract with one of those entities to actually get that data. You may find your name is at the bottom of the list, which you're not going to like, but you'll then find out why. And then you could do something about it. Have companies, corporations experiment? Yes. There are many companies that have actually put care coordinators in the worksite, and they built clinics in the worksite with a robust team of care coordinators that in fact has access to all of this data about all of the employees. Exactly. JB Hunt is one. There are tons of them. I had actually worked with a company that built boats in Maine. I can't tell you who it was, but you could figure it out from that. And one of the things that we did is we got their insurance company to invest money to hire people to actually be on site and not sell the insurance company's products, but to understand the local community and the hospitals and the local doctors and everything else that was available right on site. It was one of the most widely used services that these employees had. Once the employees enjoyed it so much, then they opened it up to the families. So they had to create a little office that was not in this highly secure work site because they were government contractors. And they built something out in a local mall. And then they had phone consults. It was like wildly successful and in fact improved the demonstrable quality, the clinical outcomes. And it actually, for the company, here's another thing that they thought about is the retention rates went up. People didn't leave the company. They said, holy shit, I'm not going to get service like this anywhere else. So I'm going to continue to work here in Maine and build some boats for these people. And if not that, they would build submarines. Somebody guessed. Right, baths are great. And Eric or whoever asked that question, the reason that this worked there, they had a very innovative head of human resources who went ahead and did it was a guy, so he did a lot of research, and then he came back to the CEO and the CFO. It was with a specific business plan, because remember, healthcare is a business, as much as we may not think about it, but it's a business. It had to make sense to this employer. And the CFO and the CEO said, oh my God, I can't believe we haven't done this before. Like, we're idiots. Why didn't we do this? And then others, because that one division of that one company, it's a big global builder of things that float across the world. They actually adopted that and put it in every other site they had across the country. Another example was Toyota did exactly the same thing. They had a clinic that was built in one of their manufacturing sites in Mississippi. And my role in this was I got hired by Toyota of Japan. They wanted to know, is this a bunch of bullshit or not? These local people are telling me it's the greatest thing that ever happened and blah. And I don't speak Japanese, but through a translator, it was like they didn't believe anything the local people were saying. So it took about a year, and it was a really in-depth analysis. And I ended up having to write like a 120-page report around why having a trusted doctor and care coordination and a specialty network like we're talking about, why that was better for people and cost a lot less. They lowered their healthcare costs 30% under what their actuaries had projected, which is why nobody in Japan believed it, because like, how could it be such a big number? They're lying, they're fudging the numbers, they just want more money in their budget next year. So it's incredibly important. I want to leave time for anyone else that's got questions. I don't know if this was helpful at all. Maybe just sharing experiences or stimulating some ideas for you. And if you ever want, Paul, you put this together, I'm happy to do like a follow-up, or if people want to send me other questions. Like I said, I'm retired. I got time. My goal is to have others, like younger people who are really practicing and are doing really innovative things in healthcare. You're the next generation that's going to fix all this BS in the system. I'm not going to be alive long enough because healthcare changes very slowly. It's $4.5 trillion. They're vested interests. Everybody who gets every one of those $4.5 trillion does not want it taken away. They'll point to everyone else in the health system, blame everybody else. It is not their fault. So don't be frustrated. Don't be frustrated. That's the main message I want to get across. This is really hard to do, but you're the kind of people that can do it. You really are, because I've seen change happen. From the 35 years I've been in this business, it's, believe it or not, much better now than it was 35 years ago. I know we all think it sucks. It doesn't. It's just difficult, it's challenging, and there's specific issues that can be fixed. So Paul, I'll turn it back to you.
Yes, Jeff, thank you. This has honestly been really incredibly enlightening, as everyone else is attesting in the comments. I think the cool part about what we have here is that this is not a one-time episodic event. You know, with XPC, we're doing care coordination for the innovation crew. And so we're just gonna take it asynchronously and continue chatting. And I think part 2 is definitely warranted. So thank you a ton. For those who are still online, if you can turn on your camera, I'll take a Zoom selfie and then we'll be on our way.
Great. And like I said, if even any of you want help with ideas around your own individual practices, feel free. I've managed thousands of primary care practices across the country in the past. So there's a lot of shit you should not do and some things you should do. Okay. Thanks so much for inviting me to the group. This was great. And I'll see you all again soon. Bye-bye.